This video is part 2 and continuation of the laceration repair video. Please watch Laceration Repair part 1 for the patient's history and setup process for the wound repair. This video will go over the process of primary closure of a laceration wound. Before you start your laceration repair, make sure adequate hemostasis has been achieved. This can be done by firm manual pressure for 10 to 15 minutes with gauze, or if still uncontrolled, lidocaine with epinephrine can be applied or injected. There are different types of anesthetic agents that can be used, from lidocaine 1% or 2% with or without epinephrine, bupivacaine, or LET gel, select the agent appropriate for the wound repair. Before performing wound exploration or irrigation, anesthetize the wound. In our patient, 10 ml of lidocaine 1% with epinephrine and 1 ml of 8.4% sodium bicarbonate is drawn up using a 10 cc syringe and 18 gauge needle. The needle is replaced with a 27 gauge needle and air is removed from the syringe. The needle is inserted through the open wound margin and advanced along the margin of the wound. Aspiration is performed to ensure the needle is not in a vascular structure. Anesthetic is injected and this process is repeated along the entire wound margin. The maximum amount of lidocaine without epinephrine should be 4 mg per kilogram of body weight with a maximum dose of 300 mg per dose, which equates to 30 ml of 1% lidocaine or 15 ml of 2% lidocaine. Lidocaine with epinephrine maximum dose is 7 mg per kilogram of body weight, or 500 mg per dose, which equates to 50 ml of 1% solution or 25 ml of 2% solution. You can buffer 10 ml of lidocaine with or without epinephrine with 1 ml of 8.4% sodium bicarbonate, a 10:1 ratio, to decrease discomfort from the acidic lidocaine. Although this is a total of 11 ml of solution, a 10 cc syringe is sufficient. Lidocaine without epinephrine results in a shorter duration of action, while lidocaine with epinephrine can provide anesthesia for up to 3 hours. Lidocaine with epinephrine is safe to use on digits, especially if there is no concern for vascular compromise. Irrigation. After about 5 to 10 minutes and confirmation of successful local anesthesia, irrigate the wound using a sterile saline solution in a 30 cc or 60 cc syringe with a splash guard attached. In our patient, 300 cc's of sterile saline is used to irrigate the wound. As a general guide, use a minimum of 100 ml of irrigation solution per 1 centimeter of wound. The wound should be cleaned without any debris after irrigation. Some wounds may require more than the suggested 100 ml per cm. Use a minimum of 250 cc's to irrigate. You can use either sterile saline, tap water, or a dilute 1:10 ratio mixture of povidone iodine solution. Do not irrigate with hydrogen peroxide as it may cause tissue damage and impair wound healing. After irrigation and visual confirmation of complete removal of debris or visible foreign bodies, clean the area of the wound with chlorhexidine and allow to dry. Use sterile fenestrated drapes if available. Most simple laceration repairs can be performed in a clean field rather than a completely sterile field. Chlorhexidine or povidone iodine may be used to clean the area of the wound. Take care to avoid applying directly into the wound. Primary wound closure is performed for clean wounds through the approximation of wound edges by direct apposition. A simple interrupted suture is one of the most commonly used suturing technique when it comes to laceration repairs. Let's take a look and see how to perform simple interrupted sutures. You can start either from one end of the wound and move on to the opposite end, or start from the middle of the wound and continue to bisect the wound until adequate closure is obtained. Using the needle driver, load the needle 2/3 of the way from the needle point. Use forceps to gently evert the wound margin and enter a couple millimeters from the wound edge. Make sure the needle tip is perpendicular to the wound margin. Rotate your wrist inward or supinate to drive the needle through the tissue. You can do this in 1 bite if the wound margins are close, or in 2 bites if the wound margins are wide. If using 1 bite, exit with the needle approximately the same distance from the wound margin as before. Release the needle and grab the needle with either forceps or needle driver and pull the suture until you have approximately a 1 to 2 inch tail. The first knot is a surgeon's knot. Place the needle driver in between the long and short end of the suture. Loop the long end of the suture twice around the closed needle driver in a clockwise motion. Make sure to move towards the wound and not away. Grasp the tail end and pull across the wound. Do not pull up. The key is to approximate the wound and not pull too tight, as this will cause tissue strangulation. The wound edges should evert and not invert. For the next knot, place the needle driver between the long and short ends of the suture and wrap the long end over the needle driver 1 time towards the wound in a clockwise motion. Grab the tail and pull in the opposite direction as before to create a square knot. The next series of knots will be done with a single loop and pulled in opposite directions to create a square knot. You can do this for a total of 4 to 5 throws. Grab both ends of the suture and cut to leave approximately 3 to 5 millimeter tails. Grab the tail ends and move the suture so the knot is not directly overlying the wound, as this will cause irritation. Repeat this process along the entire length of the wound. Dressing. After repair is complete, clean the wound with sterile saline and gauze. Allow to dry. Apply bacitracin over the wound and cover with a non-adherent gauze, followed by a dry gauze. You can use tape at this point, or you can use a gauze roll followed by tape. Make sure to document the procedure note and patient consent to the procedure. In our patient, Tdap was administered as patient was not up to date. Prophylactic antibiotics may be recommended if there is potential for future infection. Wounds such as puncture wounds or bite wounds, wounds with contamination with soil, feces, water, or interoral lacerations or nail bed lacerations should be covered prophylactically. Aftercare. Advised to keep dry with dressing on for 24 hours. Advise washing with mild soap and water twice daily after the 24-hour period. A thin layer of bacitracin or petroleum ointment twice a day should be applied. Further dressing is not necessary and the wound can be left open to air. Avoid using hydrogen peroxide or alcohol to clean the wound, as this may cause discomfort and impair wound healing. However, if crusting is present, half-strength hydrogen peroxide solution can be used to gently wipe away crusting. Showering after 24 hours from time of repair is okay, but avoid soaking the wound. Direct, prolonged sun exposure should be avoided due to concern for more prominent scarring. Advised to watch for signs of infection such as redness, swelling, discharge, fever, or pain, and follow up for evaluation. If non-absorbable sutures were placed, provide follow-up recommendation for suture removal. For the face, 3 to 5 days, scalp, 7 to 10 days, trunk, 7 to 10 days, arms, 7 to 10 days, legs, 10 to 14 days, hands and feet, 10 to 14 days, palms and soles, 14 to 21 days should be adequate. In our patient, the patient was instructed to return in 7 to 10 days. That's it for today. Thank you for watching Dr. Pearlz Clinical Rounds. If you enjoyed the video, please hit the like and subscribe button. Let's move on to the next case.